Welcome everyone to the Osteoarthritis Action Alliance Lunch and Learn webinar for August 2017. My name is Kirsten Ambrose and I want to appreciate everyone for joining our presentation this month. I hope you've all been enjoying your summer. Today, our presenter is Sandra Soto. Dr. Soto is a registered nurse, and she has both a master's degree and a PhD in public health, with a special interest in health behavior from the San Diego State University and University of California Joint Doctoral Program. As we speak, she's moving from San Diego to Chapel Hill to begin a postdoctoral traineeship at UNC's School of Nursing to build her expertise in interventions for preventing and managing chronic illnesses. In her research, Dr. Soto has examined the role of family members, social support, and social networks on behaviors relevant to the development and maintenance of chronic illnesses among Latinos, including physical activity and dietary behaviors. So today, she'll present some of her findings on leisure time physical activity among Latinas. Welcome, Dr. Soto.
Thank you, Kirsten, for the introduction, and thank you everyone for joining the webinar. Today I'll be presenting a paper that I published earlier this year with my colleagues from San Diego State University and UC San Diego on leisure time physical activity and characteristics of social network support for exercise among Latinas. So we know that leisure time physical activity is important to both mental and physical health. For example, it helps prevent the onset of chronic diseases, including obesity, diabetes, and heart disease. And it is useful in the management of diseases, including the management of osteoarthritis symptoms. Now, although the benefits of engaging in leisure time physical activity are well known, there are important disparities to consider. For example, in this figure, you'll note that women in the dark purple are consistently lower than men in the light purple at meeting physical activity guidelines through leisure time activity across age groups. We also find important disparities in leisure time physical activity by race and ethnicity, where minorities are meeting physical activity guidelines at lower rates than whites. And this is why we find that 40% of Latino women do not engage in any physical activity compared to 23% of non-Latino white women. So this high prevalence of Latino women engaging in no leisure time physical activity highlights the need for understanding the determinants of leisure time activity in this group. And two recent systematic reviews found that among minorities, especially Latino women, social support was the most consistent interpersonal determinant for engaging in leisure time physical activity. While the majority of research shows that social support for exercise is important, studies tend to limit the operationalization of social support to either the size of one's social network or the amount of encouragement received, typically from family or friends. Now, although assessing the size of the network is handy and straightforward, it is also a crude method that does not allow for the gathering of any information on the characteristics of the support received. And while support in the form of encouragement has been found to be associated with physical activity, there are many other ways that individuals may provide support, including offering exercise to exercise together or taking care of children so that a person can go exercise. Also, family members are often grouped together, but doing so may obscure the unique role that family members play in their support for exercise. For example, support from a child may look very different than support from a spouse. And finally, there are potentially important aspects of support for exercise that have yet to be examined, including the gender of the supporter, especially because among traditional Latinas, they often rely on spousal support and approval in their decision to engage in leisure time physical activity. And although support may be intended as a positive experience, it may be that recipients who are not satisfied with the support they receive engage in lower levels of leisure time physical activity than those who are satisfied with the support they receive. So one way of examining these unexplored aspects of social support for exercise is by using social network analyses. The benefits of assessing social networks is that they allow us to obtain a detailed census of those who provide support and their characteristics. And they allow for the investigation of dyadic relationships between pairs of individuals, By examining dyads, we can identify the support characteristics that are associated with leisure time physical activity. So in an effort to build an understanding of social network support for exercise, the purpose of the study was to examine the social network characteristics of support for exercise that are associated with engaging in moderate to vigorous leisure time physical activity. This cross-sectional study used baseline data collected in the group randomized controlled trial Faith in Action, or Fe en Acción. And this intervention included 16 churches across San Diego County and 435 participants. Churches were eligible if they had at least 200 Spanish-speaking attendees, if they had at least one Spanish language mass, and if they were willing to be randomized. And participants were eligible if they were between 18 to 65 years old. They did not have a chronic disease that precluded them from engaging in physical activity, and if they were low active, which meant that they either did not self-report exceeding 150 minutes of moderate to vigorous physical activity per week, which are the current guidelines, or if they did not exceed 250 minutes measured by accelerometer. So we used the Global Physical Activity Questionnaire to assess self-reported physical activity, or the GPAC. And the GPAC has 16 items that assess frequency, duration, and intensity of activity across 4 domains, including leisure time, occupational, transportation, and household activity. And this graph here shows that among the current sample, a large number of women reported no leisure time physical activity, and therefore we dichotomize this variable into none versus any. So to assess the social network of support for exercise, we use an egocentric approach, which is when participants are asked to report on who supports them for exercise. But then we do not collect data directly from their supporters, as is typically done with the sociocentric approach. That's highlighted here on the right. And so these characteristics shown here are those that were collected for each supporter from the participant, and I'll go through each one by one. We first asked participants to indicate the people who support them in their physical activity, and we clarified by saying that we were not interested in knowing all the people they share their life with, but rather the people who helped them be active in the last 6 months, even if it involved nagging them. And women were allowed to name up to 6 supporters. For each supporter, participants reported their gender, their relationship with the supporter, which included spouse, parent, sibling, child, and so on, and the ways that the supporter provided support. So, for example, reminding you to exercise, exercising with you, taking over chores so that you could exercise, and participants could list multiple ways. And finally, they responded by responding to an item on how satisfied they were with the support they received on a 4-point scale, from not at all satisfied to very much satisfied. Now, to analyze these data, I first tested whether having any support for exercise was associated with the likelihood of engaging in any versus no leisure time physical activity using the original data set of 435 women. Then I stacked the data set so that I could examine dyads of participants and each of their supporters. And stacking the data set showed that we had 569 dyads. So using generalized estimating equations, I tested the support characteristics associated with the likelihood of engaging in any versus no leisure time physical activity. And these analyses were conducted in R, and models controlled for clustering at the church level and sociodemographic characteristics. Our sample consisted of Latinas who were on average 44 years of age. Most were married, about half graduated from high school, 66% were employed, and almost 60% had a monthly household income less than $2,000. Over half of all participants did not engage in any leisure time physical activity, and over 1/4 did not have anyone who provided support for exercise. Here we see that about 1/4 of participants did not name a supporter for exercise, and almost 40% named one person, and about 1/4 named 2 people. So first we examined whether having any support for exercise was associated with the likelihood of engaging in any versus no leisure time physical activity. And we found that, consistent with previous literature, naming at least one supporter was associated with increased odds of engaging in any leisure time physical activity. Next, we explored the characteristics of the supporters by examining the dyadic data set of 569 dyads. And here we see that over half of all supporters were female. About 40% of supporters were children, about 30% were spouse, and about 10% were friends, and the others were named less frequently. And due to low frequencies, siblings, parents, and other family members were grouped into one category, and the other sources of support with 1% or less were not examined. Next, we explored the sources of support by gender, and we see that except for spouses, most supporters were female. And to improve the interpretability of the 9 types of support that participants could report receiving, the types were reduced to 4 categories shown here in the colored boxes. We used a package in R called CorePlot to cluster groups based on highly correlated types of support. So we called the first category activity partner support because it included having supporters who exercise with you or find ways to be active together. The second category was called emotional support because it included having supporters who remind you to exercise, encourage you to exercise, or plan around your exercise schedule. The third category was called equipment and transportation support because it included having supporters who provide transportation so that you could exercise, or buying equipment that you could use for exercise. And finally, the last category was called household duty support because it included having supporters who take over chores or take care of children so that you could exercise. So when we examined the 4 categories of support types, we found that most supporters provided emotional support, followed by activity partner support, and few supporters provided household chore support and equipment and transportation support. 70% of women said that they were very much satisfied with the support they received. And therefore, we collapsed the lower end of the scale together so that this variable was comparing those who were very much satisfied with those who were less than very much satisfied with their support. So we tested the supporter characteristics first in bivariate models, adjusting for church fixed effects, and then we entered those that were at least marginally significant at p less than 0.1 into a multivariate model, adjusting again for church effects, fixed effects, and sociodemographic variables. And first, this table shows that the gender of the supporter and the relationship with the supporter were not associated with the likelihood of engaging in leisure time physical activity. Also, emotional support, equipment and transportation support, and the number of categories of support received were not associated with leisure time physical activity. However, the likelihood of engaging in leisure time physical activity increased over twofold if women received activity partner support and household chore support, if they were very much satisfied with the support they received, and if they had more than 2 supporters for exercise. So this study had a few interesting findings that have potential implications for future work. The association between help with household duties and leisure time physical activity is a striking example of how a very specific type of support can be important, especially because household duties and family responsibilities are common barriers to engaging in physical activity among Latinas. However, receiving support for household duties may have resulted in women engaging in leisure time physical activity. But it may also be the case that active women create an expectation for support, negotiate support, or find individuals who will support them so that they can continue to be active. So in other words, we aren't sure on the direction of the effect. So if the alternative explanation is the case, then interventions can focus on providing women with the skills and self-efficacy to negotiate support. Having someone with whom to engage in exercise was associated with higher odds of engaging in leisure time physical activity, possibly because activity partners help with accountability and because they can make physical activity more enjoyable. Also, we know that health behaviors can be contagious, spreading through social networks. So we've seen this with obesity, we've seen it with smoking and drinking. Therefore, having members of a social network who are physically active may encourage inactive individuals to also engage in physical activity. And this ties into the concept of homophily, which is the tendency to form relationships with similar others. So birds of a feather flock together. And this may explain why women who are active form relationships with others who are also active. So the only way to untangle these associations is by using longitudinal methods. And women who were more likely to engage in leisure time physical activity were those who reported support for exercise. Sorry, women were not more likely to engage in leisure time physical activity if they reported support for exercise from one gender over the other. So it didn't matter if they received support from females or males. Similarly, we did not detect differences in leisure time physical activity when support was received from different sources. So it did not matter if it came from a spouse or from a friend or from a child. However, our findings may inform interventions that want to target naturally occurring social networks for exercise. So for example, we did find that mother-child dyads could be an important future group to work with, as many women reported their daughters as being a source of support. Now, the study must be looked at in light of its limitations. So again, I point to the cross-sectional design as a limitation. We don't know the direction of the effects for our results, and therefore we need longitudinal methods. Another limitation is that women did not free list the types of support they received. The types of support were created by the co-investigators who have conducted previous studies with Latinas and physical activity, and so they came up with these different ways that supporters typically provide support. However, we may have had more variety of types of support if we just asked women to name how their supporters gave them support. And also, generalizability is limited. These were Latinas who were inactive, who were church going. And in terms of osteoarthritis, these women included both those who did and who did not have osteoarthritis. The only limitation, the only thing that would preclude them from being in the study was if they could not engage in physical activity due to a disease. For example, high blood pressure, something that would not allow them, if their physicians would not allow them to engage in physical activity. So our study was not specific to any group of individuals with a specific disease or disorder. So the findings show that we have some important directions for future interventions. We saw that having support from more than 2 individuals was associated with increased likelihood of engaging in leisure time and physical activity, and therefore studies that can promote and build the size of one's social network could be beneficial. And we saw that household support and activity partner support were also beneficial to increasing the likelihood of engaging in exercise. And so interventions that could build these types of support, for example, giving women strategies to build networks, for example, with their neighbors. So sharing household chores. You cook dinner one night, and so that I can walk. I'll take care of your children tonight so that you can go out for a walk, for example. And then again, the study can be built on in future studies using longitudinal data that can expand these results and help untangle the direction of the effect. So I would like to acknowledge the staff of Faith in Action. The PI was Elva Arredondo and the project manager, Jessica Hutton. In case anyone wants more information about the study, which has ended, please feel free to email Jessica or myself, and also to our funders. Thank you. Any questions?
All right, thank you, Dr. Soto. Just a reminder to our attendees, you can chat any questions you have in that lower right-hand chat box. And while we're waiting for any questions to come in, I was just thinking, your presentation gave me a lot of triggers in terms of some recent talks that I've attended, and thinking back to the Movement is Life conference last year. Are you familiar with that? Have you been able to attend that conference at all?
No, I haven't.
I'll send you some information about it. It's a really excellent conference that focuses on health disparities among African American and Hispanic populations primarily. And they really always get some great speakers and cover the gamut of clinical issues and social issues. And one of the sessions that I attended the last time was specifically was relaying some information about social support for Hispanic populations, and it was a little bit different perspective than what you described here, but it put me in the mind of the woman who presented was a physician who was treating a Hispanic population in her clinic, and she had the common experience of having an entire collection of family members, or quite a few family members, join the patient in the clinic setting as that person's sort of social support network, and in a way was treating the patient and everyone. It was sort of an interesting perspective that she found to be very culturally unique to the Hispanic population where she was. So I
Yeah,
don't know
it's
if
a
you.
much more collective culture than
Mhm.
individualistic for sure.
Yeah, I think that's true. And I was also thinking about the role, the traditional gender role that seems to be prevalent in what you were describing with women who are very connected to the household chores and caring for children and may find it difficult to have space to go out and do things in
Right,
terms of leisure time. Yep.
right, right. Yeah, and I did find it interesting that we did not find that gender was important. Um, Although it may be due to lack of variability, most of the supporters, other than the spouse, were women. But given that there is such a rich source of support there from women, then I do see opportunities in the future to have women work together in some sort of, shared responsibility way so that they could, sort of share the load and be able to be more active.
I think that is important. And the other thing I was thinking about was the generalizability comments that you made about your population being church going, and put me in the mind here in North Carolina, Dr. Callahan, who ran the research trial, community-based research trial across the state of North Carolina to evaluate and validate the Arthritis Foundation's Spanish language version of Walk with Ease, Camino con Gusto,
Mhm.
and she was able to get good population participation from church-going Hispanic populations. So a lot of the locations where she had great success in recruiting patients were from churches. So
Mhm.
I was not really surprised to hear you say that. I think that's a pretty common, or certainly a good place to reach folks, for those who are listening to the webinar who are um, in the business of community-based, evidence-based interventions and wanting to reach a wide variety of the population. I think it's a great place to reach people.
Yeah, yeah. I mean, for in this case, all the churches were Catholic churches. That was not the intention originally. It just turned out that way. And with the Cac the Catholic Church is so hierarchical, we ended up getting support from the Diocese of San Diego. And um, for anyone who is thinking about working with churches, that's usually key to have, that hierarchical support. And then when it comes down to the individual church level, it really varies. Priests come and go. Um, the upper level staff, tend to switch around, and then a lot of times it's the church members who have to take over the intervention a little bit, and who, if you have their support, then that's great, but then it's also a little bit tricky if there's a change in the priest, and they may have different priorities, and they may want to take the church in a different direction. So it can get a little tricky when doing a larger scale intervention. But at least, I've collected data from churches for smaller studies, and yeah, I mean, a lot of the time it's a great resource. You just go to the church, ask to speak with Father, and meet with him, and typically it's a very open space to recruit in, especially if it has anything to do with family and health. And um, I would highly recommend churches as a potential avenue.
Hmm. Yeah, and Dr. Callahan wrote in a comment that she agreed that a large number of participants for Camino con Gusto were from churches, and they had worked with two Catholic churches and another church. And I
Yeah.
would say that in a separate Movement is Life session that I attended, we also discussed the role of churches in African American communities, which gets a little bit away from our presentation today, but the point there was that churches often serve as a community center. It's a social
Right.
center, it's a faith-based center, it provides a lot of services to the local community.
Right, it does, and it's consistent typically. So, I was talking to my mom actually recently, and she was saying how she goes to the senior center to go to art classes, and she was saying how that's a potential too, except people don't consistently go to the senior center or the rec center or the library, but people do consistently go to church. And so it is a way, if you want to do follow-ups or intervention work, it's a great way where people are very connected with that community and come back.
That's a really great point. We do have so much difficulty trying to get people to be consistent with physical activity and bringing programs to church settings. I didn't really think about it in that way, but I could see it being a way to sort of get something a little bit more consistently embedded, or having people come back to participate when they know that it's their people and something that they already have a consistent tie to.
Exactly.
So we do have one question that came in from Linda Ehrlich Jones. What was the purpose of limiting participants to those with less than 150 minutes of physical activity per week?
Yeah, so the intervention was designed to it was designed to ramp individuals who were low active up in their physical activity. So individuals who were meeting guidelines, which was 150 minutes per week, were already ramped up. And so it was an effort to focus on that part of the population that was at most risk. So those who were just not very inactive or not active at all, as opposed to maintenance of physical activity with those who are already meeting guidelines. Um, but however, the intervention in the churches was open to the intervention was the activities at the churches were open to anyone at the church. So the participants had to be low active, but a part of the intervention was leading physical activity classes and walking groups at the churches and around the church. And those activities were open to anyone. It's just that not everyone was allowed to be a participant.
Thank you. Yeah, I think it is really tough to get those folks who are not already being physically active to increase their activity, and that's such a big target population.
Yeah, and what we found actually was, because the activities were open to everyone, in many cases, a large proportion of those who were coming to our activities were not participants. These were the active people who were like, great, free classes. I'll do that. It's at my church. It's right down the block. And so so I think yeah, and it definitely helped create what we're talking about here, more social connectedness. And so I but it's just funny how a lot of our low active participants did not make up the majority of those who attended the classes.
Hmm. Yeah, and I'm not surprised to hear you say that about the folks who are already active. We've had that come up with some of our Walk with Ease participants in our mini grant program that, a lot of them want to know, can their participants bring a friend? Somebody
Oh,
who's
yeah.
either already walking with them or would like to start walking with them, but who may not have arthritis in our case, because we're trying to
Right.
reach folks with arthritis. So the target population we're trying to reach comes, but it could be that they have other folks who want to come too. So
Right, right,
anybody who wants to exercise, we're happy to have them.
right. Exactly.
Very good. Well, we are at the end of our 30-minute webinar session. I'm more than happy to entertain any other questions that come in. In the meantime, I'll just give a quick shout to our next month webinar on September 20th with Dr. Tamara Huff on musculoskeletal health disparities, breaking that vicious cycle. Dr. Huff, interestingly enough, is associated with Movement is Life. I didn't mean to make that connection, but there we are. We have a couple of webinars between today's, next month, and back in May. We had addressed health disparities and looking at African American and Hispanic population. So trying to reach everyone here. So
Nice.
haven't had any other questions come in, so I will go ahead and thank you very much, Dr. Soto, for your time and presentation today, and thank everyone for joining us.
Thank you.
Thanks. Bye-bye, everybody.